Next, John Hirshfeld is joined by Dr. Roger Blumenthal, Professor of Medicine and Director of the Johns Hopkins Chicharron Center for Prevention of Heart Disease in Baltimore, Maryland. They cover why I no longer see value in the use of niacin and fibrates, the highly difficult lipoprotein.
Roger, welcome to ACCEL.
Thanks very much, John.
So, Roger, first of all, maybe you can recapitulate for our audience what the AIM-HI trial was and what it found.
So the AIM-HI study looked at about 3,300 individuals who already had vascular disease, and they typically had HDLs in the range of 35, some lower than that, but they were less than 40. They had triglycerides greater than 150, and they all had vascular disease, and the randomization was statin alone versus statin plus niacin. What they tried to do, John, was to isolate the HDL raising effects of the niacin. So they tried to balance out the LDLs. So that meant that the statin-only arm got more ezetimibe, which lowers LDL. So one of the limitations of AIM-HI was that some of the potential benefits of niacin in terms of further lowering LDL we didn't see because they kept the LDLs the same. But nevertheless, many of us thought that in individuals all had at least two components of the metabolic syndrome, and the vast majority had what we would say would be the metabolic syndrome, that adding niacin to a statin was better than the statin alone. We had some nice data with carotid intermedial thickness from Alan Taylor. We had quantitative angiography studies from Greg Brown. Yet when the study results were looked at, after about two-thirds of the events had accrued, there was really no difference. And numerically, there were a few more strokes in the simvastatin plus niacin arm as opposed to the statin arm alone.
So to me, this raises some very interesting pathogenetic questions. We've long known that there's an epidemiologic association between elevated triglycerides and vascular risk, and there's an epidemiologic association between low HDL and vascular risk. So it seems to me that this trial can be looked at as examining whether or not modifying these two risk factors actually has pathogenetic benefit. And maybe why don't we start with triglycerides? And I guess the first question I would ask you is, do you think that triglycerides are actually atherogenic substances themselves, or are they just a marker?
Clearly, the company that triglycerides keep are important. So when we have above average triglycerides or below average HDL that tends to go along with the higher triglycerides, we tend to see more of the smaller, denser particles, and maybe it's just because there's more LDL particles, a higher ApoB content that seems to be associated with a higher risk. So we still don't know for sure if lowering triglycerides has a major impact on atherosclerosis. We have old studies such as the Helsinki Heart Study that showed in men with high non-HDL cholesterol, predominantly high LDL, but those who had high LDL plus high triglycerides, we saw a substantial lowering of risk with gemfibrocil. And if you look at all the fibrate studies, that subgroup of triglycerides greater than 200, HDL less than 35, there does seem to be a consistent trend for benefit. And the good news, John, is that it looks like the VA medical system is going to start a study with add-on of fenofibrate on top of a statin versus a statin alone in those individuals with elevated triglycerides. Whether that's going to be above 200 or above 250, I don't know if it's been announced, but we clearly need some more randomized controlled data.
Okay, so let's switch to HDL now. So if we know that low HDL is epidemiologically associated with risk, so what about raising HDL, either through niacin or through the CETP inhibitors? What do we know about that in terms of how beneficial that may be?
Well, in addition to AIM-HI, we had disappointing news from HPS-2 Thrive, and in that study, we looked at a different niacin preparation along with laropaprint, which was given to try to minimize flushing. And it's unclear whether the disappointing results of HPS-2 Thrive were related somehow to this novel compound laropaprint. We'll never really know. But I think our enthusiasm for raising HDL also went down when we had the torcetrapib data, and then we had the dalcetrapib data. Torcetrapib was the first large CETP inhibitor program, and we think part of the reason that did not work was that there were off-target effects, perhaps a rise in aldosterone levels that led to significant increases in blood pressure and perhaps 20% of the participants. So we're all waiting for the data with anacetrapib, the DEFINE study. And in that study, we expect to see that the HDL levels will be doubled, along with a lowering of LDL and triglycerides. So our enthusiasm, John, for raising HDL is certainly going down, and the new guidelines certainly are very statin-centric.
I wonder whether, to a degree, the reason that these trials weren't positive, particularly in the context that the FATS trial with niacin alone or with bile sequestering agents was positive, is that statins are so powerful that they sort of overwhelm any effect that we might see from these other agents.
I agree with you. Actually, in the debate that I had with my friend Henry Ginsberg, I showed a baseball slide. I showed the slide of the great Red Sox pitcher Pedro Martinez, who used to always say that the Yankees were his daddy. And then finally, after Boston came back from a 3-0 deficit and beat the Yankees, he could say that he was the Yankees' daddy. So I changed that to say statins are hyperlipidemia's daddy. And I think right now we don't need to routinely add niacin or fibrate onto individuals unless we have an individual who clearly has the elevated triglyceride above 200 with that very low HDL. I think in ACCORD there was some enthusiasm for treating that dyslipidemic group with the high triglyceride, low HDL, but you also have to balance that, John, with the fact that in women, there is a trend for more events with fenofibrate. And that's hard to sort of reconcile that fenofibrate, when you add it on, may be detrimental in a subgroup and may be positive in a different subgroup. And I think where I'll continue to use niacin and fibrate is in that high-risk secondary prevention, individuals who have already had a major cardiovascular event, who really want to do whatever they can to minimize another event. I will tell them that right now the data is suggestive that triglyceride lowering and HDL raising with niacin or fibrate may be helpful in that dyslipidemic group with the high triglyceride, low HDL, but unfortunately we just don't have the evidence that we'd like.
Well, it certainly sounds like a very practical approach to this problem, and I think it's as evidence-based as we can be at this point. And I gather that even though you've moved to Baltimore, you have not embraced the Orioles.
I grew up a Washington Senators fan, and my son is a Boston sports fan, and he liked the Red Sox, so we became Pedro Martinez fans.
Easy guy to love, too. Well, Roger, thank you very much for sharing these ideas with our ACCEL audience. I think they're very valuable and will help people improve the way they take care of patients.
Thank you, John.